Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
We're going to talk targeted therapy on this episode to figure out what we're going to title it, because I think we're going to talk through a lot of things. A while ago, I asked you, it was probably almost a year ago now, I asked you what gets you to an ASCO. I don't know if you remember that. I just listened to that episode. That's why it was top of mind. So maybe now I need to ask you, by popular demand, what will get you to do a podcast shirtless?
A podcast what?
Shirtless.
Shortlist?
Shirt without your
shirtless.
shirt.
Oh, shirtless. I don't know. I'd need to think. Yeah, and the reason you're saying this for other people's benefit is because Owen doesn't work when I do it. No, it's not. Oh, yeah. Oh, your hit rate is so high. Owen suggested this to me this morning at the gym, a topless podcast. Not just shirtless, if you see what I mean. Yeah. I don't know. I'm not sure about that. I can't think of anything off the top of my head. Go on.
And honestly, when Owen suggested that, he was only talking about you. He was not insinuating that I would be topless on it. He was truly
listen, when you meet him, you have to ask him.
He's your gym trainer. I think he just wants to show off his work, right?
Oh, I see. Yeah, so he's got a conflict of interest then. Yeah, okay.
He's got a vested interest. I wouldn't call that a conflict. I wouldn't call that a conflict. That's a vested interest.
Yeah, he might have some conflicts of interest as well, actually. But yeah, we'll park that one.
Okay.
And then on a subsequent episode, I'll ask you the same question.
When am I going to?
Yeah, listeners and viewers, watch out for that subsequent episode.
This is not nice for our colleagues that know us professionally. This is garbage part of the episode. Yeah, but really only to entice people to our YouTube channel. We're trying to see if you guys are interested to come over and like and subscribe. It's Melanoma Matters Pod, and we have our own channel, and we put the videos there. In order for the algorithm to know, though, to help you, and just so that you don't have to go searching for this podcast, you do have to like and subscribe. It's not monetized. It's not going to cost you anything. It's not going to spam you. It's just going to, and you can turn off your subscriber notifications, but if you wanted to know when a new episode is released, then you'll get it that way. Also, it just helps drive more of these, shows if you like them. So
that was smooth.
Yeah, that's just
that was effortless.
The teaser is you will be shirtless. And that will drive. People will just have to click through every video to find out when are you going to be.
Yeah.
And we'll just stick it in somewhere in the middle. We'll just be very serious talking, and you just whip it off.
Yeah.
You chat for 2 minutes, you put it back on.
So it's a bit like the Golden Ticket and Willy Wonka.
Say more
You're
about
familiar with that? No.
In theory,
it's the principle of it, isn't it? That you don't know where it is, and you just have to go through everything to find out.
It's warming up for you there, so maybe this is a reality. Okay, targeted therapy.
Yeah, mainly MEK inhibitors, right? That's what we're going to talk about, because it's an interesting subject. Maybe that should be the title. I don't really know.
Or maybe we'll call it Finding Nemo. Are we allowed to call it that? Probably not. But this came up because we wanted to do a podcast on the NEMO trial, and I kept wondering what happened with that FDA approval or ODAC vote. And then I was searching for that. Turns out it never went to ODAC, but we can talk about that. So how do you want to sequence this? Because there's actually a few randomized MEK inhibitor trials.
Yeah, well, listen, I mean, maybe by way of background, MEK inhibitors have been around for a really long time. I think the first time it was on my radar was 15 years ago, maybe. So AstraZeneca have got one, right? AZD, sorry, 6244, selumetinib. And actually that drug's been around for a long time. And then now there's 3, 4, 5 other, probably more MEK inhibitors. Yeah, you were going to say what? You raised your hand, Professor Patel.
Actually, giving it away here, but guess who had an oral presentation as a fellow on AZD 6244 in melanoma?
I'm going to guess that was Dr. S. Patel at the time from MD Anderson Cancer Center. Yeah. And the year, I'm going to guess the year as well. 2011, 2012.
You had the first maths right.
Meaning?
You said it came across about 15 years ago.
Oh, 10.
2010. Guess who was my discussant? Who's a big MEK inhibitor person? RAS, MEK, RAS, MAP kinase.
I don't know, Neil Rosen.
Yeah. So it was his disciple, Dave Solit.
Yeah. So can I just say, I just got quite a lot of consecutive things almost right. Yeah. And I didn't cheat. I didn't cheat either on any of those.
You're right. So the other way we were going to get you shirtless was if you got things wrong, we were going to have a strip poker situation. So I don't know what you get for getting things right.
Well, that builds credit in the account, doesn't it?
Okay.
So I think that was close to 3 consecutives.
Yeah. Well, I was going to say is, so 644 actually had 2 different formulations. There was a hydrogen sulfate formulation and then a capsule formulation. And that was one of the early ones, but it had the whole reason that got an oral presentation, I think, is for the first time we were saying, hey, look, this MEK inhibitor here works in BRAF, but it also is seeming to work in NRAS patients. So Dave Solit was the discussant. One of the first persons on the microphone to ask a question was Neil Rosen. And then side note, this was back in the day, and I haven't seen Dave in years. I think he was on our external advisory board for our SPORE, but at the time and potentially still current state, he was considered pretty handsome.
Hey.
Side note.
Will that automatically make it into the show notes or not?
That Dave is handsome?
Yeah.
Sure.
Yeah. That's good. Because if you're scrolling through them.
Dave Solit, handsome.
Yeah. Okay. Very good.
Keywords.
So, yeah. So what I was going to say, so I think that was one of the first ones, if not the first one, the AstraZeneca one. They all have pretty characteristic side effects, I think, as well, and maybe we're talking about that now. Certainly when you use them as single agents. So rash in particular, especially on the face, that can be quite troublesome. Acneiform rash for the patients, we find, and we'll often ask our dermatologists to see the patients, but even then, sometimes despite best efforts from dermatologists, antibiotics, creams, that kind of thing, still troublesome. Edema can be quite troublesome with MEK inhibitors as well. Carry on.
Sorry to interrupt my normal. It's because we've been talking about this a lot today off camera, that we will induce a lot of side effects with our treatments that the specialists for those areas are then, sort of obligated to manage, but they're managing it per the textbook for the kind of classic presentation. Yep. So just as you said, the acneiform rash, if this was like a regular acneiform rash, not necessarily drug induced, this is why they use antibiotic, topicals and blah, 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 but that's really minimally effective. And eventually, finally, our dermatology group at Anderson, a cool woman named Anisha Patel, shout out to Anisha, really came around on this and was like, that's not going to work. That's not
no relative, just checking, no conflict of interest. Okay, carry on.
And anyway, so yeah, I mean, it's that we cause these side effects. They are going to, for years and years and years, try to treat it sort of the classic way until somebody kind of has a light bulb moment and says, maybe there's a mechanism driving this and we're calling it acneiform because that's what it looks like. But guess what? It's not clogged pores in the classic sense and blah, blah, blah. Anyway.
Yeah, so that's a great point, I think. A really great point. And that, my biggest beef here is with neurological toxicity. I think in the early days, this whole business about trying to effectively shoehorn what we're seeing, if that makes sense, or put a square peg into a round hole, or however you want to describe it, the things that particularly checkpoint inhibitors, are causing into classical descriptions of neurological syndromes, most of which were developed in the 19th century, often by French neurologists, at least going on the eponymous syndromes. But guess what? Why would they be the same? How could they be the same? Because people weren't using checkpoint inhibitors in the 19th century, to my knowledge, anyway.
We know that Lambert-Eaton looks like myasthenia gravis, but has a different mechanism. So we just need to get comfortable probably renaming these things so that, that they basically can be described differently. Was it David Cunningham that taught you all that?
What? All that stuff in the 19th century?
All those neurological terms?
No, Tom Newsom-Davis.
Oh, Tom Newsom-Davis.
Yeah. Shout out to Tom, who sent me a nice message. I told you that. His son, who's an oncologist. Anyway, so I think that, we're labouring it, aren't we? We're digressing a lot. But the side effects, I think, certainly not just in my experience, but actually if you look at the literature and everything else, for MEK inhibitors are not necessarily that easy for a lot of patients. I mentioned the edema. That can actually be difficult. Sometimes you can get pleural effusions. And then the other thing, just to point out with MEK inhibitors, is the ocular toxicity as well. I think, honestly, it was more scary at the start, the ocular toxicity from MEK inhibitors, and a lot of the trials had sort of built-in very detailed ocular exams and stuff like that. But I think it's one of those ones that actually in clinic you use the drugs a little bit more. You can see some visual disturbances, but they'll almost always settle down. I hardly these days, admittedly, we're mainly using with BRAF inhibitors. I hardly ever see major ocular toxicity, but you've got a point. As our viewers will note, and if you're listening and not watching, Sapna's got a point. Go on.
You can tell by my facial expressions. So this is going to be a forever long episode. We're going to have to cut to the chase quick. So what MEK inhibitor do you use that you're not as concerned with ocular toxicity anymore?
Well, with trametinib, not particularly, honestly, and also binimetinib. Those are probably the main ones that we're using at the moment. But yeah, you're going to tell me it's different for different MEK inhibitors.
Yeah. So Bini, for sure, you can almost treat through the blurry vision that comes because then it settles down. Trametinib, it's not so clear, and that obviously that's a half-life difference too. Then I don't know how well our ophthalmologists have a great handle because we're probably using it less. We're using it in more advanced cases after checkpoint, and then is it uveitis? Is it trametinib? It's that.
I thought a lot of it was serous retinopathy.
So it's uveitis with checkpoint, and then it's the serous retinopathy. There's something called an Amsler grid. Are you familiar with this? Amsler grid.
Yes, I am.
So whenever you prescribe a MEK inhibitor, theoretically, you should be giving your patients an Amsler grid. It's a piece of graph paper, essentially, and they hold it at arm's length, and they should always be able to see the lines, and they should be straight. So when people develop central serous retinopathy, which is fluid in the eye, they'll essentially have gaps in that graph paper, or the lines will be wavy. Or they'll say when they're driving on the road, I don't know how the lines are in the UK, but in the US, they're fairly straight. In Germany, sometimes they can be all over the place. But in the UK, they're fairly straight. And if those lines start, on the freeway, if they start bending to your eye, then you've got fluid in your eye. So that's...
So I've had central serous retinopathy.
Oh, word. Why?
Because there's an idiopathic version of it as well. So, this is a digression on digression. But I could tell exactly when it happened, actually. I was doing a rotation in Maidstone, which is in Kent, and I was driving there from London. First thing you notice is halos around lights at night when you're driving, basically. So I got worked up for it, and that, central serous retinopathy settles down, basically. I might have had another episode since then as well. And in the books, it says that it's really common in pilots. I suspect that's rubbish. I suspect it's just pilots that notice it and get immediately to medical attention, obviously, because you don't really want pilots with visual problems. So I'm kind of quite tuned into that as a side effect, actually. But now I was going to say something else, and this is going to risk a fact check, I'm afraid. But I'd understood that it was about Cmax, your chance of getting serous retinopathy, and I've now, unless you know differently, committed ourselves to a fact check on that. But we can probably park it for now because we've had a long discussion about side effects, I suppose.
We didn't mention cardiac, did we?
No, carry on.
Sudden cardiac death, drop in ejection fraction. It's just worth noting.
Yeah. That's real. I mean, if you're doing echoes, serial echoes on people, you will quite often get a drop in ejection fraction.
Well, and also here's the problem is the labels for these drugs, I think, talk about this and they say consider, but they don't have really strong language of how often should you be getting echoes. So many people will get, will start people on this without a baseline. And then what are you going to do? Because as we said before, a lot of these cardiac side effects like myocarditis with checkpoint inhibitors, the patients don't come in with the sign saying my ejection fraction is dropped, right? It's all these very vague symptoms, shortness of breath, maybe some edema, maybe lack of endurance for sport or whatever. But it would be good to get a baseline. And then I just sort of try to train our trainees that think of staging or scanning the heart every time you scan for tumor assessment. So if you're going to scan every 12 weeks, then think about getting a heart scan to the point where there's good tolerance, and then you could maybe do that less often, but you should still do it at intervals. And that's the same for me for immune checkpoint inhibitor thyroid or immune checkpoint inhibitor when I'm concerned about other things. Anyway, okay, carry on. So metric trial you described, right? Or did you not?
No, and so that's sort of the question, how do we do this? But we could try and do this chronologically, and maybe that's the best way to do it. And I think, so without talking about non-randomized trials, I think we saw early on from non-randomized trials, there was a signal for single-agent MEK inhibitors in melanoma. And then, of course, the question is going to be, is it a particular genetically defined subtype? So the first randomized trial, I think, was metric. And so this was trametinib versus chemotherapy in BRAF mutant melanoma. So Keith Flaherty, hey Keith, was the lead author of that. Dirk Schardendorf, senior author. We did that trial. I think Paul Nathan did it as well. I'm looking for his name. Yeah, Paul was there as well. A few other people. Global trial. So phase 3, 322 patients, V600E or V600K mutant. Trametinib or chemo, 2-to-1 randomization, and you can have either dacarbazine or Taxol given according to standard doses. So and I'm reading the abstract, obviously this was NEJM, July 2012. Wow, it's almost 13 years ago. So the median PFS, forgive me, was 4.8 months in the trametinib group, 1.5 months in the chemo group, and the hazard ratio there, 0.45. with confidence interval 0.33 to 0.63. So obviously highly significant. Sorry, go on.
That's the primary endpoint of that one is PFS?
Yeah. OS, I think the primary endpoint, was PFS, OS secondary endpoint. OS, this is a landmark at 6 months, 81% for the trametinib group, 67% for chemo. And there was crossover as well. So the hazard ratio for OS was 0.54, again, significant. Tox we've described, we didn't mention diarrhea, but what they comment on the abstract is rash, diarrhea, and edema. And they also note the ocular and cardiac side effects, although they were less frequent, obviously. So PFS advantage, OS advantage for trametinib versus chemo. You're laughing at me. In BRAF mutant melanoma. So I guess that shows you that there's a signal. That tells you something about toxicity in a decent-sized trial conducted in multiple centres, so not just a kind of phase 1-2 type of experience. But I suppose my comment, obviously, about BRAF mutant melanoma is that by then, and this is 2012, right, we already knew pretty clearly there was a solid signal for vemurafenib versus dacarbazine. We knew that dabrafenib was active, and the combos were a little way along by then. So I think that in terms of further development of single agent MEK inhibition, I think the activity we were seeing for BRAF inhibitors and BRAF MEK meant that it didn't really happen, but carry on.
I don't know if we actually, first of all, I wasn't laughing, I was smiling, which is what you I'm not laughing, I'm smiling. Did we actually say what the chemotherapy was here? It was dacarbazine or...
Yeah, you weren't listening. I said it was dacarbazine or Taxol at standard doses. Okay. Would you like to know the standard doses as well?
No, I just missed it. Sorry. Got lost in trying to give you something to trip you up so you might take your shirt off, but okay, try again. Okay, so metric study was the first one. What's the next study?
Yeah, that's a good question. What is the next one? Well, so I guess that was BRAF mutant melanoma.
Yeah,
Sorry?
that was BRAF. That was BRAF. We could talk about NEMO because NEMO is binimetinib versus the carbazine for NRAS positive. So then the focus for single agent MEK really started to go away from BRAF positive because by then we knew it was, BRAF patients were really going to do better if they got the combination. It improves tolerability of your BRAF inhibitor. To some degree, it improves efficacy. That's debatable in the Columbus 7-year data, I think, the long-term data, but side note. But then, so they really, when they were moving on to MEK inhibitors monotherapy, they started looking at the BRAF wild type population, which in some ways also included uveal melanoma. There's activation of the MAP kinase pathway, but then they also honed in on this NRAS pathway, so RAS mutant melanomas. And so we got the NEMO trial for that. And the NEMO trial, I remember Jeff Sossman presented this in 2016 or so at ASCO. By 2017, it's come out as a publication. I've lost my window here. Let me just see if I can find it. So they ended up filing an NDA, a new drug application with the FDA for the NEMO trial. And they had the PDUFA date, the Prescription Drug Users Free Act, which is where they review it and then ODAC will vote on it. They had that scheduled for June of 2017. So I think it was a year after the ASCO presentation. Fact check it if that's wrong. But then I kept looking what happened. I thought that was a positive study and kind of what happened to so I don't know if you have the article pulled up. I've just got a kind of a press release here.
And I do. I can just go through it. Yeah. Is that all right?
Yeah.
So our good friend Reinhard Duma is the lead author.
Say that one more time.
Reinhard Duma. Keith Flaherty, senior author, Lancet Oncology, April 2017. So just to do the detail a little bit. I don't know how they got the acronym NEMO. Actually, I was just wondering that. Maybe we could fact check that as well. It's not jumping out. It's not jumping out at me. Okay. So phase 3 study, 118 centers in 26 countries, 2-to-1 randomization. Patients who had progressed on previous immunotherapy or treatment naive, randomized 2-to-1. Binimetinib 45 milligrams twice daily or dacarbazine standard dose. Obviously, NRAS mutant melanoma, primary endpoint, PFS, central review in intent to treat. So the study recruited 2013 to 2015, sort of about 18 months, 400 patients altogether, 269 binimetinib, 133 dacarbazine. Median follow-up, 1.7 months. Doesn't seem very long, does it? Yeah, that's what it says. I'm reading the abstract. Median PFS, 2.8 months for Bini, 1.5 months for dacarbazine. Hazard ratio 0.62, confidence intervals 0.47 to 0.80. So there's your positive trial, as it were. Then, sorry, second.
For PFS.
Yeah, for PFS.
Was this going to be this isn't okay? I'm sorry to take us back in history here, but we think the agency was going to accept a PFS endpoint for a phase 3 trial back then. Would have thought the OS bar was so low, previously treated melanoma. Anyway, interesting, right?
Yeah, agree. No. That's a good point, but it's the primary endpoint of the study. And again, in the abstract, just looking a little bit about toxicity, the differences between the two arms, there's a bit of hypertension. We sort of didn't exactly say that, 7% for the MEK inhibitor, not much for the dacarbazine, as you would imagine. But maybe this is important, and it's the very final sentence. Serious adverse events, all grades, occurred in 34% of patients in the binimetinib group, and 22% of patients in the dacarbazine group. So that's a 12% difference in serious AEs or grades. So that's obviously blunt to say that, but it does make the point, and we were talking about this before we started recording, and we actually have laboured the tox a fair amount, but these are drugs actually that do have a non-trivial amount of side effects. And obviously if you're seeing a real upside for efficacy, then you can live with that as a clinician. Patients can live with that. Regulators can live with that. But I think that's kind of the issue. I'm going to make one final point. And I think the problem with MEK inhibitors is the narrow therapeutic window, basically, because, all of our cells now are signaling through the MAP kinase pathway. So there's only so hard I think you can hit it with a single agent MEK inhibitor in terms of dose. And so that limits your therapeutic window. And I think that's one of the problems with the drugs as a class. And I'm going to ask you again, and you can come back and tell me the answer in a bit, about what labels there are for single agent MEK inhibitors in the whole of oncology. But before you do that, you were going to make another point.
Yeah, I'm going to give you a fact check within a fact check, because I think fact check within an episode.
Yes.
Right? Intra episode fact check. We like those, right?
That's my thing, by the way.
Your herpes. For the viewer, if you want to check.
That's my gardening injury for the
check out
of the record.
So, minute 25 times 27. He calls it a gardening injury. It's a herpetic whitlow on his. Okay. Listen, it just means you were using your hands. Good for you. That's got to use all parts of the body. So good for you. Okay. So NEMO stands for NRAS Melanoma MEK inhibitor. So the NRAS melanoma, hang on, NRAS.
So where's the O coming from? It's the O in inhibitor.
It's the O in inhibitor. It's the E in melanoma. NRAS melanoma MEK inhibitor.
I mean, that's a stretch, isn't it?
That's your
pulling an O out from inhibitor.
That was the fact check I wanted to give you. And then this trial, did you say it? They had to have a Q61 mutation. They didn't take G12?
That is a difficult question, which I can't answer from the abstract, so we need to fact check that properly, I'm afraid.
It's fine. Good. The other point I was going to make is just read this vote. So if indeed PFS was the primary endpoint, as you read out, positive, all these things, they filed this NDA with the FDA. So I was looking for the ODAC vote. Like, what happened to it? This is a positive study. Why do we have an indication for this? We also say, maybe for the listener, when you're treating a patient and you're kind of running out of options. So here's what happened. Array ended up pulling the NDA. It sounds like they had conversations with the FDA that phase 3 data that you just read out. How many patients was that in the NEMO study?
Yeah, 400 overall, 269 on binimetinib.
269 on binimetinib. Okay, that's interesting. So Array pulled it. They basically said, it looks like after talking about this, that despite it having a positive primary endpoint, positive everything, the remainder of that data, the clinical benefit demonstrated in the phase 3 NEMO clinical trial, would not be found sufficient to support approval of the NRAS mutant melanoma NDA. So the PDUFA that was in June of 2017 was canceled. And this is in the totality of a response rate of 15% for binimetinib versus 7% for dacarbazine, and a median overall survival at 11 months for experimental and 10 months for chemo. So yeah, we've got some PFS, but we have a very mild doubling of an objective response rate, and essentially a difference in overall survival of a month that didn't seem to really cut it. So yeah, so that's really interesting. They ended up pulling it. Okay, so that's NEMO trial. And then I think you came up with one more randomized.
Yeah, I think it's worth mentioning this other randomized trial. It's randomized phase 2 in NRAS mutant melanoma. So Pimasertib. I'm not quite sure how you say that. And I'm not sure. Sorry?
Pima. Oh,
okay. Sertib.
Yeah. I mean, but you could say Pimasertib if you just want to.
It may be academic.
Emphasis on the wrong syllable there.
Right. So this was published in Cancers, parentheses, Basel, or I suppose Basel, if you're a first language speaker. 2020. Celeste Lebe is the lead author. Brigitte Trino is the senior author. Again, it's an international study here, although mainly looking European. I think maybe it was a Europe Europe only study. I think it was actually. Oh, no, there's some in New Zealand as well and US. Okay, anyway. So this is MEK1 and 2 inhibitor versus dacarbazine, NRAS mutant melanoma untreated. Phase 2 open label, randomized, 2-to-1 randomization. Pimasertib dose 60 milligrams orally twice daily, dacarbazine standard doses, crossover permitted, primary endpoint, investigator assessed PFS. 194 patients randomized, 130 got pimasertib. And then the PFS, I'll read out the medians first, 13 versus 7 weeks, hazard ratio 0.59, favouring the MEK inhibitor. Confidence interval 0.42 to 0.83, so it's actually a very similar result, which is, I think, why it's worth.
Is this the first one giving it to us in weeks?
Say that again?
Is this the first one giving it to us in weeks instead of months?
Yeah, but the hazard ratio is really similar. OS was actually pretty similar, not statistically significant, remembering there was crossover allowed in the trial. And then this is again from the abstract with apologies. Serious AEs, 57% for pimasertib versus 20% for dacarbazine, and it's kind of the same list of things we talked about. We didn't, I don't think, mention CPK rise, but just maybe mention that in passing. So I think actually that the efficacy signal there is actually sort of relatively consistent with NEMO, and it tells you that there is some activity there. But I guess the take home is, maybe for me anyway, there's a bit more efficacy than cytotoxic chemotherapy. But actually, if anything, I'd say that there's more toxicity for MEK inhibitors at these doses than, say, for single agent dacarbazine, which, you know, is actually relatively well tolerated, or temozolomide for that matter.
Yeah, what an interesting point. When you said it, when we were just doing some show notes before recording, I hadn't really contemplated that, but that's a good point, right? And you're getting it here in the numbers that, you know, here are two drugs that are not that much. And how can that not be on a regulatory body's mind? Because they have to consider safety and tolerability in addition to efficacy. So now you have like a marginal efficacy benefit, but it's less well tolerated. Okay, let's end this with the quiz question you had for me, and then I have one for you that you're definitely.
Oh, hang on. So you'll have cheated by now, I'm sure. But anyway.
No, I didn't look it up.
Okay. Carry on.
You asked MEK inhibitors approved for what? I actually have no idea. It's approved for it's not approved for one of these weirdo Langerhans histiocytosis glioma.
To my knowledge, yeah. So you've lost a point there, I'm afraid. And I think the answer is serous ovarian cancer. I think there's a label for a MEK inhibitor in serous ovarian cancer. We probably will need to fact check that afterwards. But to my knowledge, actually, I ask the fellows and registrars this question quite a lot when we're talking about targeted therapy and MEK inhibitors. And, you know, I give them a similar speech or speeches to the ones that I've just given you. But it's actually really interesting. I think you've got efficacy without doubt, probably in lots of different indications, but just not enough to really beat, you know, and with chemo, it's not like we're talking about really active drugs here in melanoma. Let's be honest. Imagine doing a randomized trial against a checkpoint inhibitor or something.
Okay, the question I'm going to ask you that you're going to know, because you actually taught this to me, and you can just, you know, store up your bank points. Credit, yeah, your credit. What? That wasn't really a good hand gesture, was it?
You're just deliberately trying to sort of, you know, promote the visual, which I'm with you, obviously.
People come to our YouTube channel. And just to be clear, we are self-funded. We are not making money off of this. We are spending money doing this. And we don't get anything other than your, you know, just like, yeah, it's just good to get the feedback.
Kudos. All of that kudos.
Well, we don't need the kudos, but
brackets joke. No,
yeah. Okay. So the question to you is, what is the number one cause of CPK elevation in central London?
Oh, of course I know the answer. So my friend Peter Hill, hey Peter, who's a nephrologist, we were medical SHOs together. My first, let's get a heart. Peter. Yeah. Let's get a heart for Peter.
Oh, it's not working.
I think it's somehow got You know, there we go. I was going to say it's like its favourite is Owen, but you've just because he gets more hearts than anyone, right? But anyway, me and Peter and I were medical SHOs together. My first job, SHO job, at the Hammersmith Hospital, an institution that you've graced with your presence in the past, doing cardiology, 1997. And Peter had already been an SHO for a year, so Peter kind of looked after me when I was a very behind the ears junior doctor anyway. So we're still friends and we work together now. Peter's a nephrologist. Anyway, so the answer, which you know, because I've told you before, rhabdo actually, rather than CPK elevation, the commonest cause of rhabdomyolysis in London is CrossFit. And that's because people aren't doing it right. And just do a safety warning here. So when you go to the gym, make sure you're well hydrated. Don't be going when you're taking non-steroidals, just rest if you're needing to take non-steroidals. And if you've had a bit of a layoff and you've been resting for a while, do not go crazy with GHDs or pull-ups or any of those kinds of things. Just take it easy and then you'll be fine.
Glute ham developers for the novice listener or for the novice channel. And also, when you get sore from a workout, don't medicate with non-steroidals.
No, definitely hydrate properly and try not to medicate with anything. And if you really, really need to, maybe some paracetamol. Yeah. But not non-steroidals.
That's like there. Yeah. Okay, super. Anything left?
Fun.
That was fun. Long episode. We'll do a bit of editing here, I think. Maybe not.
Very good.
Thanks.